Good morning. Well, it's refreshing to see that not everything is different in Saudi Arabia compared to Canada. Early morning starts are always difficult to get going, but thank you for coming. I know there will be people coming in as I speak. What I wanted to do to begin with, though, was to share with you some of the memories I have of where I come from, for those of you that haven't experienced Western Canada before. I think Western Canada is well known for its mountains, and this is a picture taken just outside the city of Banff, a very famous mountain called Mount Rundle. That's actually, a lot of its stone is imported for stonework across the country, called Rundle stone, but a very scenic area of the country. So as I say, Canada, Western Canada is known for its mountains and also its forests and its rivers. Much of our natural resources come from these rivers, including much of our electricity that is produced by generators that capture the moving water and turn it into electricity. We also have freshwater lakes, which you can kind of make out here at the bottom, and with the lakes come spectacular sunrises and sunsets. There's very much wildlife. I'm privileged. This picture, you can actually see an image here, was taken through my back window out onto our backyard, and this is a newborn deer. We don't have camels, but we have moose. They grow very big antlers, the males, and they're probably about the same size as camels. And this is a cow moose, a female, that's camped outside our backyard, lying in the grass, and of course enjoying some of the salt we put out for them. I think moose actually share some things in common with camels. You can see that they don't really have a hump, but they have a growth area in their back that contains fat, similar to the camels, and their legs work in similar ways. And as I say, they're similar sizes, but we would never dare get on the back of one of these animals. They're very wild. We have caravans in Western Canada. This one is mine, and it looks like this is very much roughing it in without services, but the inside of the caravan has everything you could want: television, surround sound, upholstery, fridge, freezer, stove, washroom, shower, bed. So it's everything one could want, and we go to the mountains on the weekend and enjoy the scenery. But when you camp in the mountains, you have to also expect the unexpected, and of course that comes with cold temperatures and snow. And winter is very much where we are in Canada at the present time. This is a view from the top of the Selkirk mountain range, which is about a 45-minute drive outside of the city which I come from, Calgary. And the cold temperatures freeze the water and make everything, of course, very cold. So we have to find things to do when it's cold. One of those things is skiing, and one of those things is surfing. And yes, you did hear me correctly, that's surfing, even in the wintertime and the snow. So we may be a bit crazy, but we do find ways to enjoy ourselves even when the temperature gets very cold. So whether it's enjoying the mountains or the winter, this is the city of Calgary where I come from, and it's called home. And I wanted to thank you very much for inviting me into your home, and hope that one day I might be able to reciprocate and welcome you to my home like you have here. Shukran. So with that, what I'd like to do is to launch into business this morning and talk a little bit about spinal cord injury. Amro heard parts of this talk a couple of years ago when he was in Toronto before he came to Calgary. And I think sometimes we tend to get lost in this whole drive for evidence-based medicine. And not that medicine shouldn't be evidence-based, but sometimes when we're looking at the evidence, I think we tend to forget how much evidence we have that may not be answered by a prospective, randomized, clinically controlled trial. Not every question, as we heard yesterday, especially in the debates, can be answered by a prospective randomized controlled trial, and yet there is still good evidence for much of what we do. And what I hope to show you this morning is some of the evidence for what we do in spinal cord injury and why we should continue to do it, even though we may not have a prospective randomized controlled trial. The initial injury that comes with a spinal cord injury is referred to as the primary injury, and that's the injury that happens at the time of the accident. It's irreversible. We can't treat it unless we were to somehow cause regeneration. I won't be talking really about regeneration today. I'm going to be talking more about neuroprotection, trying to keep working what we have working. But the primary injury can really be broken down into a number of different mechanisms: contusion, compression, deceleration, shear, distraction, laceration. All of these words translate to what you're seeing here. Basically, hemorrhage or hemorrhagic contusion in the middle of the spinal cord from an odontoid fracture or other fracture dislocations farther down the spinal column. So as I say, the primary injury is something that occurs at the time of the event and basically is set. When we try and treat spinal cord injury today, what we're actually trying to treat is secondary injury. And that's the cascade of events that occurs after the primary injury that goes on to claim or kill neurons and axons and supporting cell structures once the injuries happen. The things that have been linked through animal experiments with secondary injury are extensive, and I don't mean to dwell on this, but just to give you a feel, hypoxia can worsen a spinal cord injury, ischemia, intracellular ionic shifts, cytotoxicity, eicosanoid production, free radical production, lipid peroxidation, etc. Much that is common to this cascade is something that you've probably heard more about recently called the inflammatory pathways, cytokine production, metalloproteinase production, and all of those are linked, as I mentioned, to further neuron and axon damage after the primary injury occurs. So what we're really trying to deal with when our patients come to the emergency department with an acute spinal cord injury is preventing the secondary injury. And in order to review this for you, I like to break this down into a mnemonic, a way to remember it, and one of the most simple ways to remember how to treat your patient with a spinal cord injury is to think of it in the form of our basic trauma protocol, which has taught us A, B, C, D, and E. Now, I don't go by everything that ATLS, Advanced Trauma Life Support, calls each of these letters. Instead, what I'll do is show you how I refer to these letters to remember how to treat spinal cord injury and why we treat it that way. A stands for arterial oxygenation. And this is a very important thing to remember when you're faced with a patient with acute spinal cord injury. I'll show you why. The lungs, as you know, are responsible for transmitting oxygen into the bloodstream, and the oxygen is then pumped through the heart to the most important organ of all, the spinal cord. And if you look at normal respiratory function here in this diagram, what you can see is we'll look at functional vital capacity, the amount of air we move in and out, and the negative inspiratory pressure, the amount of vacuum we can create when we inspire. And in you and I, sitting here today, we have a functional vital capacity and negative inspiratory pressure of about 100%, which makes sense, and we're resting comfortably with a sinusoidal rhythm of breathing. Now, in a spinal cord injury, what happens? Oh, pardon me, I missed. Oxygen saturation is comfortably not sitting at 100%, but around 93 to 95%, depending on whether you smoke or not. The spinal cord injury, as you will recall, typically occurs in the lower cervical, upper thoracic region, and although in most cases the phrenic nerves are preserved and our diaphragm function is preserved, most of the spinal cord injuries that we see involve various degrees of intercostal muscles. And when you lose your intercostal muscles, particularly with low cervical or mid-cervical spinal cord injury, that's when the changes of arterial oxygenation really start to occur. So here's our normal diagram, and here's where we are right now. What happens immediately with a spinal cord injury is that there's an acute drop in our functional vital capacity and our negative inspiratory pressure. And this is basic physiology. We all learned it in medical school, but we tend to forget it. And instead of this normal sinusoidal rhythm here, we find a very much more shallow breathing pattern as our functional vital capacity and negative inspiratory pressure drop to 1/3. With a cervical spinal cord injury, C6, C7, T1, our FVC and NIP drop to 1/3, 30% of what we're used to. The reason for that, as you can see, is that we're breathing only by our diaphragm. In fact, the intercostals, because they're not working, don't help, but the chest wall becomes more compliant and actually gets sucked in with each breath, and this is called paradoxical breathing. So as the diaphragm drops, the chest wall actually moves in, and that increases even more this amount of dead space that is being ventilated. It's air that's moving in and out of the airways, but is not getting transformed to oxygen in the bloodstream. As a result, the amount of oxygen in the bloodstream that's available to the spinal cord decreases. Now, you don't see that at this point yet in the O2 saturation. The O2 saturation is still staying up around 93%, yet the reserve, the oxygen reserve, because of this pattern, is very much reduced. So is that important here in the middle of the injury where the blood clot is and there's no blood flowing? No, it's not. That's the primary injury. It's out here where the axons are still viable, that they're still potentially functioning. They may be electrically silent, but they're not physiologically dead yet. That's where this reduced oxygen reserve can be important. Now, when we're monitoring these patients in our intensive care units and in our spine units, one of the things people will get caught by is monitoring the oxygen saturation, which, as I mentioned, even at this point is normal. It's only when the patient starts to fatigue and drops their FVC and NIP less than 30% that the oxygen saturation starts to fall off. By that time, when the oxygen saturation is falling, it's already too late. It's like holding your breath for a half an hour or maybe an hour while you've got reduced blood supply, reduced blood oxygenation now affecting this penumbra of very sensitive tissue. And so if you're monitoring oxygen saturation, by the time you get here, you're already creating ischemic damage to this area that is so sensitive after injury. So it's this combination of paradoxical chest wall movement, the accessory muscles of inspiration, which are weak to begin with, and then they fade even more, and the relative increase in dead space that leads to this very slippery slope that happens very quickly, and usually we're not thinking of in advance, and we should be. Well, this doesn't last forever. What is it that eventually gets us out of this? Our spinal cord injured patients, how come they don't exist forever in this low oxygen type of picture? The reason for that is spasticity. What happens with the spasticity is it affects not only the lower limbs and the upper limbs, but it affects the chest wall too. So much of this paradoxical breathing becomes eliminated as the elasticity of the chest wall goes down and the stiffness goes back up. But the reality is that 1/3 of cervical spinal cord injuries require intubation, 33%, most of them within the first 24 hours. The things that go wrong first is that people develop an increased respiratory rate, they develop increasing fatigue, decreased vital capacity, and increasing PCO2, not a decreased oxygen saturation. When you look at these patients, their O2 sats can be normal, but they look hungry. They look hungry for air, and that's when you can tell that they're starting to get into trouble. So if you're going to monitor something, don't go by oxygen saturation. Go by functional vital capacity or negative inspiratory pressure. And your respiratory technologist can help you with that. B is for blood flow. Now, I'm going to spend a few minutes on this again because I think the concept's important, and it's something that's linked to oxygenation, but also is important on its own. So this will be also not only linked to oxygen content, but blood pressure. This is a cross-section of the spinal cord, a colloidal carbon angiogram, and what it shows you is that the blood flow is very much dedicated towards the gray matter. It enters through the anterior spinal artery and the paired posterior spinal arteries, flows to the gray matter, and then outwards radially towards the pia through the white matter. And it's this area that gets affected first as spinal cord blood flow changes. This is a classic experiment reported from Martin and Doberstein in 1994, performed in monkeys, and it has to do with cerebral blood flow. But everything I'm going to tell you about cerebral blood flow has been established in the spinal cord as well. This diagram shows that between cerebral blood flows of 50 to 55 milliliters per 100 grams per minute is normally where you and I perfuse our gray matter at this particular point in time. As we drop cerebral blood flow to levels of 20 to 25 milliliters per 100 gram per minute, we see altered consciousness and EEG changes. If we drop even just a little bit lower than that, 18 to 20 milliliters per 100 grams per minute, then neurological deficits start to occur, or coma, and the EEG becomes flat. Now, this is called electrical silence, but it's not cell death. However, within a few points of that, 12 to 17 milliliters per 100 grams per minute, then we start to see loss of evoked potentials, the sodium-potassium pump fails, and cell death will occur after hours. A few more points down, 10 and below, there's complete ion pump failure, cytotoxic edema, calcium channels open up, and cell death occurs in minutes. So within this very tight range, you can go from healthy nerves that aren't quite functioning properly to membrane disruption and irreversible cell death. And as I mentioned, this applies to the spinal cord as well. Now, in normal conditions, under physiological conditions, how is it that we protect ourselves against something like this happening when you faint or pass out, when you have an episode of low blood pressure? Well, this is data from spinal cord as well. I mentioned it to you. It not only applies to the brain, but to the spinal cord. Here's spinal cord blood flow measured in milliliters per 100 grams per minute. And this is the actual data plotted by the line. And then you can see the curve that's generated from that, the hypothetical data. And what this shows on the bottom is mean systolic blood pressure. Does anybody recognize this curve? Can anybody tell me what the name of this relationship is? Probably maybe one of our vascular neurosurgeons, if there's anybody in the room. It's called autoregulation. And just like there's autoregulation in the brain, there's autoregulation in the spinal cord. If I can translate this for you, you can see here across the bottom scale within a physiological range of mean systolic blood pressure, say 60 to 160 systolic blood pressure, you can see that this curve of spinal cord blood flow is essentially constant. So whether your systolic blood pressure is 60, as it feels like for me right now, or whether it's 160, your spinal cord blood flow is sitting right around that magic mark of 50 to 55 milliliters per 100 grams per minute. Well, that's all fine and well for us who are sitting here now. What happens under these circumstances where you have a hemorrhagic contusion in the middle of the spinal cord and this very, very sensitive area on the outside where blood flow is tenuous at best? Well, we know what happens there too. Here's some more curves indicating autoregulation and spinal cord blood flow. Instead of graphing at the bottom here, mean systolic blood pressure, what you're seeing here now is PaCO2. And so this is the other side of the autoregulation curve. This is before injury. This is animal data. This is in a normal animal that has normal autoregulation in the spinal cord. But instead of mean arterial blood pressure or systolic blood pressure, what you see here is that when you start with a low PaCO2, you're hyperventilating, spinal cord blood flow goes down. When PaCO2 goes up, when oxygen will also go down as PaCO2 goes up, then blood flow goes up, and that's a very linear relationship. You recall the S-shaped curve I showed you in the other graph. On the other part of autoregulation is this linear relationship between PaCO2 and spinal cord blood flow. Drop the PaCO2, drop the spinal cord blood flow, increase the PaCO2, increase the spinal cord blood flow. After injury, quite a different story. Now, this isn't at the injury epicenter. This is not in the middle of the injury. This is around the injury, the surrounding viable tissue outside the injury. And what you can see is instead of a nice 45-degree angle slope to this line, it becomes almost horizontal. And what that means is even though your PaCO2 drops, your spinal cord blood flow no longer drops. Even though your PaCO2 might increase as your oxygenation goes down, your spinal cord blood flow no longer goes up. And so this shows us that around the area of injury, spinal cord blood flow, this whole relationship that keeps our gray matter and our neurons healthy, is gone. So one of the downstream effects of spinal cord injury, at the level of injury where the tissue is most sensitive and can either live or die, spinal cord blood flow and autoregulation are very much disrupted. Well, let's go back to one of our schematics. What does this mean when the patient comes to emergency room and then to the ICU? Well, as you'll recall, the cardiac sympathetics come out from T1 to T4, and the peripheral sympathetics come out of the spinal cord from T1 to L2. So any type of mid to lower cervical injury, again, the most common ones that we see in North America, will affect not only the cardiac sympathetics, but the peripheral sympathetics too. Hypotension, bradycardia, the classic two parameters that change with spinal cord injury. Let's take this back to what's happening. This is a longitudinal section of an animal that's had a spinal cord injury. You can see right here is the epicenter of the injury, and this will be the tissue on either side that is at risk for secondary injury. Here's our spinal cord blood flow. This is the slippery end, the area where we start to get cell dysfunction and then eventually cell death. And then I'm going to put up our curve again, our normal curve. So trying to tie all this together, what I've been spending the last 10 minutes talking about, when we have our normal autoregulation, what happens to this after spinal cord injury is that instead of a flat curve with mean systolic pressure, that there's constant spinal cord blood flow throughout a range of systolic pressures. What happens is we develop this. So as systolic blood pressure drops, spinal cord blood flow drops too. And so things, because of the cardiac sympathetic interference, the peripheral sympathetic interference, the tendency in our patients is to fall down this curve, and that means we tend to lose our patients in this area of secondary injury around the epicenter of the spinal cord injury. The good news, I'll play it again, the good news, instead of this happening, if we support systolic blood pressure, if we push systolic blood pressure in this direction, because autoregulation is missing, we can reverse the curve and push spinal cord blood flow back up. So in normal circumstances, if you augmented blood pressure, you would have no effect in the spinal cord because of autoregulation, but because it's disrupted, as we push blood pressure up, we actually increase spinal cord blood flow on this axis. And we can push the penumbra in this ischemic area, we can push it out of this range back up into a safer range of spinal cord blood flow by altering perfusion pressure. Has this been demonstrated? Well, as I mentioned, not in a prospective randomized controlled clinical trial, but many of you may be familiar with the paper that came out of Alabama from Mark Hadley and his group, published quite a while ago now, where they looked at augmenting spinal cord blood flow and mean arterial pressure in an ICU setting over a 7-day period. Now, they didn't run any controls, but what they did was they compared to historical controls. And just to familiarize you with these graphs, this is the paper, cervical cord injuries, thoracic cord injuries, and this is the percent of patients that were ambulatory after rehab at the end of their study. This is the presenting ASIA grade that these patients came in with, and you'll recall that ASIA A is the worst grade and ASIA E is normal. So here's the data for cervical spine. If you look at your own practices before you dive into these graphs, and you ask yourself, of your ASIA A patients, the ones that you see motor and sensory complete cervical spinal cord injuries that come to you in the emergency department, how many of your ASIA A patients would you expect to walk out of hospital. What percent would you expect to be ambulatory? Typically, for an ASIA A cervical spinal cord, I'd say less than 5% in my practice. And usually that's because they change their ASIA grade from A to a B within the first 24 hours of injury. In Vail's study, with their 7-day ICU stay and perfusion pressure augmentation, they found in follow-up that 30% of their ASIA A's walked out of hospital. 5 out of 6 of their ASIA B's did, and I think that's 7 out of 8 of their ASIA C's. Interestingly, in the thoracic cord, as we know, thoracic cord injuries are a little harder to treat, a little more severe. The spinal cord's a little more tenuous, blood flow's tenuous. So not as many of their A's did well, but look at how many B's. 80% of their ASIA B's walked out of, thoracic ASIA B's walked out of hospital. So compared to historical controls, this data at the time and still is reasonably exciting. Is there anything else? Is it just one paper, or has there been anything else to substantiate this? Yes, in fact, there have. All of these are class 3 data, but in 1993, 91, 84, even back as far as 1976, people have found with class 3 data that there seem to be improved outcomes when you control or support your patient's blood pressure instead of letting it bottom out with their hypotension and bradycardia. So this shows us how what we know in the lab makes sense clinically. Will we ever see a prospective randomized controlled trial for this? Probably not. But does it make sense to treat our patients in this way? Yes, absolutely, it does. This is something we've been experimenting a bit with in Calgary. This is clinical data from a MINOCYCLINE trial that I'll tell you about in a few minutes. We actually were looking as a second part of this study at augmenting spinal cord perfusion pressure, bringing it up higher to a mean arterial pressure of 85. And we had 3 groups. This is our early results. The green line are people who had thoracic injuries, and so they never got into trouble with hypotension or bradycardia. They're kind of our control group. And then in our cervical cord injuries, we looked at people who we didn't treat. We randomized them to not treat them versus a group of people we did treat with spinal cord perfusion pressure, mean arterial pressure support. And you can see those who we treated tended to change their ASIA scores more favorably over a follow-up of a year compared to those who we did not support. So our experience in Calgary echoes that of the literature, that spinal cord perfusion pressure, mean arterial pressure can be an important thing to control in these patients to help improve their outcome. So I think in today's day and age, although it may not be a guideline, it's certainly a treatment option and perhaps a recommendation. Don't let your patients be hypotensive following a spinal cord injury. Correct hypotension if the systolic blood pressure especially is less than 90 millimeters of mercury, with crystalloid, colloid, and even blood transfusion if you have to. Inotropes, alpha and beta adrenergics, dopamine and norepinephrine. We tend to use the norepinephrine in our ICU. And consider augmenting the mean arterial pressure to 85 or 90 for 7 days. It's expensive. ICUs aren't always open to this suggestion because it takes up a bed. You have to have a central line in. You're probably ventilating a cervical patient at this point, but consider it, and I think you won't be disappointed. C is for complications, and these people are very prone to complications. Again, this is nothing new, but something we tend to forget. Pneumonia is the leading cause of death in people with spinal cord injury. Depending on the series, 27 to 43% mortality. It's because of loss of abdominal control, and strep, pseudomonas, and staph are the usual offenders. Now, how would you diagnose a pneumonia? Well, typically, we look for fever. Do you always see fever in a spinal cord injured patient? Not always. What else will we look for? Well, changes on the chest x-ray, right? We always do chest x-rays every day in ICU. Have a look at this. The American College of Chest Physicians says that to diagnose pneumonia in anybody, not just spinal cord injured patient, you need at least 2 criteria. Temperature greater than 38 or less than 36. Well, that's not very helpful. Leukocytosis, white blood cell count up, or white blood cell count down. That's not very specific either. Purulent secretions, hypoxemia. Does anybody see chest x-ray here? No. And the reason for that is because the changes in chest x-ray lag by 3 to 5 days after the onset of pneumonia. So by the time you start treating a chest x-ray, this has been going on for several days, including hypoxemia. So it's very important to remember in our spinal cord injuries, be vigilant. Don't just rely on the chest x-ray. When their secretions start to change, when their white count changes, when their temperature changes, jump on the infection, because the downstream effects will affect the recovery too. Thromboembolism, 7 to 100% depending on how you measure it. Venogram is the most sensitive, but we don't always do that. Prophylaxis in North America is a treatment standard, which means if you don't do prophylactic DVT control, the lawyers will have a good time with you. But we do. This is very standard for our patients to receive some level of DVT prophylaxis. Pressure sores cause skin necrosis in 2 hours. Low critical care priority because our ICU people are looking after airway, blood pressure, and spinal instability. That's what they're thinking about. They're not really thinking about pressure sores. But it's a source of sepsis, chronic disability, and death. And it's a tragedy when a person dies from a spinal cord injury because of a pressure sore, very similar to what happened to Christopher Reeve. The prevention is easy. We don't transport on a spine board over long distances. If the distance is more than 2 hours, we put them on an ambulance stretcher at the scene and get them off the spine board. The spine board doesn't help protect them at that point. Turn and log roll the patient every 2 hours. That's where this came from. If you're not doing that, then these people are going to get pressure sores. And don't forget to have a look at that sacral region frequently. Nutrition may or may not play a role. It's still controversial in the literature in preventing pressure sores. Okay, here's the fun part. D is for decompression. There have been some attempts to look at this in the human literature. I'll touch on these briefly, but I wanted to show you some very beautiful animal work done by Chris Shields and his group back in the early 90s, I believe, on the influence of spinal canal narrowing and timing of decompression on neurologic recovery. Chris is out of Kentucky. He originally was a Canadian and went south to work and came up with this beautiful idea. This is a rat model of spinal cord injury, and this is an impactor that hits the spinal cord. And what they did was delivered an incomplete injury to these rats, and then they took a spacer, and they put the spacer, it's not quite on the screen. You can see it on the television monitors on the side, but we're at the bottom here. But on the television monitors, you can see that they took the spacer, and they put the spacer after the injury inside the spinal cord canal. So basically what they did is delivered the injury and then took these different spacers and they maintained spinal cord compression for different doses. The spacer was different thicknesses over different times. And this is what they found. On this axis, you can see the behavioral outcome of the animal. 20 is a near normal score, 0 is no movement at all. This is the recovery period, 6 weeks. Here is when they injured the animal and didn't put a spacer in. So the animals had an incomplete injury, did reasonably well. As you can see, when you increase the thickness of the spacer and you leave the spacer in 1 hour after injury, as the spacer thickness increases, the performance of the animal decreases. So what that means is the more compression you have on the spinal cord, the worse the outcome's going to be. It's not rocket science. It's not even brain surgery, but it's very compelling data. This is the corollary where they took...
Excuse me, sir.
Yes, please.
Some slides are not coming.
Okay.
So we had to change the resolution.
Okay.
1026. Can you go to settings?
We're going to change the resolution so that perhaps you can see this better.
Resolution 1026. Yeah.
24?
24, yeah. It'll be okay. Perfect.
Thank you. So this is the corollary or the sister experiment to the first one that I showed you, where this is the first one, just to remind you, we were looking at different thicknesses of spacers. Now in this experiment, again, here is the functional outcome, the ability of the animal to walk. This is the time after the injury. This is looking at a 0.69 millimeter spacer, 20% canal compromise. And the longer you leave that spacer in after injury, 2 hours, 6 hours, leave it in for a day, leave it in for 3 days, the worse the animal does over the recovery period. And what that tells you is that not only is the thickness of compression a predictor of outcome, but the duration of compression is a predictor of outcome. So here's a picture paints 1,000 words. Here are the cross sections of the spinal cords. This is with the spacer left in for 0 hours, left in for 2 hours, 6 hours, 1 day, and 3 days. If you had a choice, which of these pictures would you take for your spinal cord? And that's a pretty easy decision. And so this is a beautiful experiment that shows us not only is it important to decompress the spinal canal completely, but it's important to decompress it quickly. Do we need a prospective, randomized clinical trial to show us this in human beings after a study like this? Well, I don't think so. It's interesting to contemplate. It's interesting to perhaps do one to show us, though, what we already know to be true. Is there any evidence in the literature besides this lovely study by Dr. Shields and his groups? Well, yes, there's quite a bit of animal evidence. And in fact, there's also some human evidence, but as you can imagine, because of the heterogeneity of our patient population, it's more difficult to prove. Timing of decompression, similarly, there is animal data. Hard to prove in humans, but there is a number of studies that do help show it. Most recently, Staskus, which you've probably heard about at meetings, and I hope will be published soon by Michael Failings and his group out of Toronto. Okay, well, we're in the home stretch. I'm going to wrap up now with the last part of our ABCD. I wanted to spend a few minutes on the extras, the neuroprotection strategies, the pharmacological interventions that we might think about. Now, I'm not going to talk about regeneration, as I mentioned. I'm only going to talk about neuroprotection. But if we had a regeneration strategy, this is where it would come in with the extras. Don't forget about these, though. I think these are even more important than what we're going to talk about now. Most of you will be familiar with the NASCA study that was published, NASCAS 2 in 1990. And the second part of NASCAS 2 was published in 1992 with the one-year follow-up data. I recently had the privilege and opportunity to work with the AANS and CNS, Joint Section on Disorders of the Nerves and Spine, to look at the guidelines updated. And we first reported this in Pittsburgh in September, so this is pretty new. It looked at we updated the guidelines for 2012 on pharmacological interventions for spinal cord injury. Mark Hadley was the chairman of our committee. Beverly Walters helped him out, and then there were the group of us, Sanjay Dal from Emory, Daniel Gelb from Maryland, myself, Curtis Rozelle from Birmingham, Nick Theodore from the Barrow in Phoenix, and Bijan Arabi from Maryland, and, Tim Reichen from Iowa. What we were charged with is going over about 680,000 citations, and we had to thin them out and come up with the papers that were important to talk about methylprednisolone and how steroids might be of use in spinal cord injury. As of 2001, when the first guidelines were written and published in the journal Neurosurgery, this was the data that was available to us back then. There were a handful of Class 1 studies, prospective randomized trials. There was a Class 2 study and a handful of Class 3 studies. And because of these three types of data, at that time in 2001, in the journal Neurosurgery, the Guidelines Committee published that administration of methylprednisolone for 24 or 48 hours is recommended as an option in the treatment of acute spinal cord injury. This goes on to say, which you can't see on the screen, is evidence is moderate, but the people treating spinal cord injury should know that the risk of complication is as high as the risk of benefit. Well, since then, despite all the papers we had to review, there were only a few new ones. There was one more Class 1 study that's come out in the last 10 years, so this is as of 2011, a couple of more Class 2 studies, and 5 more Class 3. But in reviewing these papers, what the Guidelines Committee was able to come up with this time is that, and this will be published later this year, and helps us in North America. I suspect that methylprednisolone didn't make as much of an impact here in the Middle East as it did in North America. But there exists no Class 1 evidence that methylprednisolone at any dose is beneficial. Level 1 evidence exists that high-dose methylprednisolone can result in death, and the conclusion now is that methylprednisolone should not be routinely administered to patients for the treatment of acute spinal cord injury. So we've seen a complete about-face as far as methylprednisolone goes. And in fact, in Canada, we surveyed our surgeons in 2001 when the first guidelines came out, and about 80% of them were either using NASCAS 2 or NASCAS 3 protocols. If you add those two bars up, they come up to close to 80%. There were only a few of us not using methylprednisolone at that time, but then in 2006, 5 years later, you can see how that changed. Nearly 80% of surgeons were not using it in 2006, and I believe now in 2011 that curve will be even higher. Our house staff, our residents, were following practice. So if you don't think what you teach has an impact on how your residents behave, you can see it's almost a mirror image. So methylprednisolone has really, I think, dropped out of the picture of these extras. There's an anti-no-go antibody owned by Novartis called ATI 355. This is a clinical trial that's just wrapping up and hopefully will be published this year on preliminary data. The myelin, as you know, is a non-permissive substrate for regeneration of the axon and neuron. And what the no-go antibody does is it interferes with the myelin antigen and dissociates that interaction so that the neuron will then go ahead and regenerate. This is an antibody developed by Martin Schwab almost 2 decades ago now, and it's just now coming to clinical trial. We'll see what those results are over the next few months, I hope. Olfactory and sheathing cells, this opens up the whole debate about progenitor cells or stem cells, and the idea is that if you inject progenitor cells or stem cells into the area of spinal cord injury, you can enhance regeneration. Still infancy, work in its infancy. Are there any exciting results I could tell you about? No, and in fact, some of the more aggressive and up-to-date results are happening in this area of the world, which we still wait and keep our fingers crossed will help with spinal cord injury, but the jury is still out. Riluzole, there's a trial gearing up in North America. It's a sodium channel blocker, FDA approved for ALS, and it attenuates the extent of anterior horn cell death, reduced cortical spinal tract degeneration. It's a planned phase 1/2A clinical trial that should be starting, but we won't hear about results of that for several years. And what I want to close off with is a project that's been near and dear to my heart, MINOCYCLINE, which is a semi-synthetic analog of tetracycline. It has antimicrobial activity and is commonly used in the treatment of acne. There's over 30 years of experience with this particular drug for this particular condition. In our favor is that oral administration results in 95 to 100% absorption, so it's easy to deliver. Although in a person with spinal cord injury, you have to negotiate the ileus that most of them have, and it's highly lipophilic and therefore readily enters the CNS. So those are all good things. As it turns out, it's not just an antimicrobial, but it's an anti-inflammatory. And I mentioned inflammation in part of the secondary injury cascade. So the idea and the animal evidence has shown us that it may be of effect in modulating inflammation after spinal cord injury. This is a project that I was lucky to be involved with in 2004, 2005, results published in 2006. This is a control animal that did not receive minocycline, and you can see this is 12 weeks after spinal cord injury. As the animal tries to navigate through this open field, the hind limbs really don't move. There's a spastic reflex flick of the tail, I think, that we see right here, but really no hind limb function. And in a separate group of animals, we delivered minocycline intraperitoneally, And this is the same spinal cord injury delivered in the same method, and you can see that 12 weeks after injury there's quite some coordinated hind limb activity, and in fact the tail is also moving to help balance the animal. So for us this was very exciting. We published this in 2006, and what was most interesting to me, having been on the negative steroid bandwagon for some time, if we looked at, here's our minocycline animals, and this is over a month. We did follow this out to 3 months, no difference. Here's their BBB score, their functional outcome. Here's our controls. And then if you looked at where methylprednisolone, the steroids, actually changed these animals, it really didn't, not compared to controls. So even compared to the methylprednisolone effect, we were excited with the minocycline. We had the opportunity to take this into humans, and this hopefully again will be published later this year, a preliminary trial that we did only in our institution, a single institution study. We randomized 52 patients with spinal cord injuries to receive either placebo, saline, or minocycline infusion for 7 days. And this is just looking at the results that again will be published hopefully in Brain later this year. You can see here's our cervical spinal cord injuries, and this is our control group. On this axis, is the change in Asia motor score, and on this axis is the time in days out to 1 year follow-up. And you can see that the patients who received minocycline did substantially better than those who received saline. This was 29 patients out of our 52 who had cervical spinal cord injuries. The thoracics, which made up the rest of the group, the thoracic spinal cord injuries did not show this effect. They tended to be more severely injured. If we looked at our incomplete spinal cord injuries, all comers, cervical and thoracics, once again we saw that our minocycline treated patients seemed to improve much more compared to our placebo patients. And even in our complete cervical spinal cord injuries, there seemed to be an effect in our completes. So this has given us reason for hope, and we will be taking this into a multi-center trial over the next 5 years throughout Canada. But I think what I want to leave you with is not so much the excitement over minocycline. I'm sure you share that with me. But most important to my talk today is to remind us of what we do up here. Before we even get to minocycline, before we even get to riluzole or stem cells or ATI 355, we should be thinking of these 4 things up here, and I hope from the last 45 minutes that I've spent talking to you about it, you can understand why that's so important. Not just that it is important, but why it is so important. I need to acknowledge, of course, several organizations that have helped with some of the research that you've seen, as well as my co-authors, and thank you very much for your time and patience.